Hello, I'm Natasza Millan from Medical University of Silesia, and I would like to share a presentation about multimodality imaging in coronary artery anomalies, current standards, and future perspectives. Here is a plan of my presentation. First, I would like to share information about coronary artery anomalies, some definition and some data. Then talk about imaging diagnostic possibilities, share a practical algorithm of steps to diagnose and confirm the anomaly, and conclusions. So let's start. Coronary artery anomalies are congenital abnormalities involving the whole course of a vessel, origin, course, and termination. And in majority of cases, they are incidental findings during other imaging methods being performed and mostly benign in nature. However, some of them are associated with serious consequences, even sudden cardiac death. And to talk about sudden cardiac death, the anomaly that is associated with it mostly, it's the anomalous origin of a coronary artery from the contralateral sinus of Valsalva. And some research describe association with malignant ventricular arrhythmias, and because of that with SCD in up to 20% of cases. So I would like to talk first about computed tomography, then echocardiography as a screening tool, and other methods, magnetic resonance and nuclear imaging. So first, the gold standard coronary computed tomography angiography. It gives a three-dimensional volumetric assessment of the coronary vessels, allows to evaluate the whole course of a vessel and also its relation with other structures of the heart. It allows to make the risk stratification and to select the best treatment method and the vascular or classic operation. And it has proven superiority over conventional coronary angiography in adults. However, in children, coronary angiography is recommended as a gold standard. And its limitations, its heart rate if it's too fast, and vessel size if they're too small. There are some high risk anatomical features that can be observed and need to be described in computed tomography, and it's intraarterial course, intramural course, acute angle of origin, stenosis of the proximal vessel segment, and elliptical shape of the vessel lumen. And we can ask a question: what is the most prevalent coronary artery anomaly? And it depends on research because some of the works say it's anomalous origin of the coronary artery from the contralateral sinus of Valsalva, but other that it's anomalous origin of the circumflex artery from the right coronary sinus. And here is an image of volume rendering technique that allows to get 3D model of a patient's heart to depict the left anterior descending artery arising from the right coronary artery and its intramural course. Next one, echocardiography, which is a first line tool that could be even described as a screening tool with low cost, no radiation exposure, and no need for iodinated contrast. However, it depends on the expertise of the operator and also the patient's anatomy, the patient's acoustic windows. And it is used for raising clinical suspicion of anomaly and also to evaluate its physiological effect on the heart's function. The view mostly used to visualize the coronary ostia as parasternal short axis view. And of course, if anomaly suspicion occurs, the patient need to be referred for CCTA. And what is important, absence of any signs of any indicators of coronary artery anomaly does not definitely excluded. Of course, transesophageal echocardiography is also method of imaging. It has superior spatial resolution and it's more proximal to the aortic root. However, CCTA remains superior in depicting the arteries and especially some specific trajectories like interarterial or intramural. Here are some images of the artery anomalies, especially with the Doppler technique. Mm, the first one, A, for example, is showing the left coronary artery originating from the pulmonary artery. What about stress echocardiography? It is a functional test for ischemia and plays a complementary role to previously described methods. And what is important in the context of suspected coronary artery anomalies, only exercise based stress testing, no pharmacological testing is recommended. Cardiac magnetic resonance, complementary approach. It is a good tool for patients that cannot undergo CCTA due to allergies to contrast media or due to some concerns about radiation exposure. For example, for children or pregnant. Mm, and it is a gold standard for quantifying left and right ventricular function, volumes, and myocardial mass. So it is a good tool to evaluate the hemodynamical effect of the anatomical change of the anomaly. In case of children that I've mentioned before, unfortunately, they need a general anesthesia to keep without moving during the examination. Here is an example of cardiac magnetic resonance used to depict anomalous left coronary artery from the pulmonary artery after surgical correction. Next method, nuclear imaging, both single photon emission computed tomography and positron emission tomography. They are used for in a myocardial perfusion imaging way. They are used for diagnosing ischemia However, only involves imaging of the left ventricle. It is not well described or standardized for the right ventricle imaging. And what is interesting, MPA SPECT is more accessible and cost effective and has improved with the introduction of fast cadmium zinc telluride gamma cameras. However, more research in this topic is needed. Here is an example of nuclear imaging, both stress test and rest test. It was a patient with no documented history of any heart disease and was referred for perfusion testing due to symptoms of heart failure. And in a rest phase, scans demonstrated normal perfusion exclusively in the inferior and mid septal segments. This is the white arrow. And moderate perfusion impairment was observed in the lateral wall segments, while the remaining areas of the myocardium exhibited severe perfusion abnormalities. In the stress phase, green arrow, the extent of perfusion defect extended to the apex of left ventricle, and the patient was referred to perform CCTA, which revealed a coronary anomaly. It is not standard way because the patient first underwent nuclear imaging process and then CCTA. Normally, it's first CCTA as a gold standard, and then as a complementary method, nuclear imaging. Here it was unusual because the patient was an old man with symptoms of ischemic disease. What about future perspectives? Some novel three-dimensional imaging tools like virtual reality and augmented reality or 3D printing. These are methods mostly described in the context of educational purposes, but may be useful in the future. So let's talk about diagnostic algorithm. First, there is some kind of clinical suspicion. I will move to the next image for a moment. So, clinical suspicion, like symptoms of ischemia in patients with low pretest probability of atherosclerotic disease, a family history of coronary artery anomalies, or any sudden cardiac death history in patient's family, and also the presence of concomitant congenital heart defects. I will go back, and then with this kind of suspicion, the patient can be referred straight to the gold standard CCTA if the suspicion is strong, or can be directed to echocardiography as it is easily performed in most places. It's also rather cheap without contrast, so it can be some kind of a screening tool. And if any signs in echocardiography are detected, then the patient is referred to perform gold standard CCTA. Also, mm, if there is any kind of lack of information, the patient should be referred to perform magnetic resonance to depict fibrosis or myocardial dysfunction, and to nuclear imaging methods to assess ischemia. Hmm. So, one more time, when transthoracic echo is not enough, in case of any specific or probably specific echocardiographic findings, in case of symptoms of ischemia, family history, and presence of concomitant congenital heart defects. And now, conclusions. So, despite the potential clinical significance, coronary artery anomalies remain understudied, probably because of the heterogeneity of their presentations. And first, the gold standard is coronary angiography. Then, as a screening tool, echocardiography, transthoracic echocardiography may be used, um, and complementary methods, cardiac magnetic resonance, and nuclear imaging modalities. To sum up, multimodality imaging nowadays is essential in certain cases. It's not just helpful, so it can be described as a standard. Thank you very much, and here is my email address in case of any contact need. Thank you.